Usually, when we talk about a medical diagnosis, there's this expectation of precision for you as the patient. It feels like engineering,
Right,
right?
totally. Like it's very binary.
Yeah, exactly. You break your arm, the x-ray shows this jagged white line, and the doctor just points at the film and goes, well, there it is.
Right. It's comforting when medicine is that simple, broken or not broken.
But then you step into the complex aftermath of cancer treatment, and suddenly that x-ray machine is just
Yeah,
useless.
the landscape gets incredibly murky.
It really does. So welcome to today's deep dive. We are sorting through this massive stack of clinical guidelines and medical journals for you, focusing on a condition called genitourinary syndrome of menopause.
Or GSM for short.
Right, GSM. And we're looking at this specifically in oncology survivors, which brings us to the core mission for this deep dive, like our central medical mystery today.
It's a really compelling one, too.
Right. So when managing severe tissue dryness and atrophy in a cancer survivor, should a clinician rely on localized tissue pH stability as their primary tracking metric for success?
Wow. Okay, so to even start to answer that, I mean, we have to look at the unique reality these patients face.
Because it's not a normal situation.
No, not at all. For a lot of breast cancer survivors, their long-term treatment involves medications like aromatase inhibitors.
Which are life-saving drugs.
Absolutely life-saving. Their entire purpose is to systematically scour the body and just starve it of estrogen.
Because estrogen fuels certain types of breast cancer cells.
Exactly. But, the body is a totally interconnected system.
Right. So by purposefully suppressing that estrogen to save their life, the medication inadvertently triggers this rapid, severe onset of GSM.
Right. It's not like natural menopause where it happens gradually over years. It is a sudden, harsh drop-off.
And looking through the clinical guidelines we have here, I mean, the symptoms are brutal. We aren't just talking about mild discomfort.
Oh, no, it's severe.
The sources describe severe tissue dryness, tearing, and this condition called dyspareunia.
Which basically means excruciating pain during intimacy.
Yeah, and recurrent urinary tract infections.
And those UTIs, they can become chronic. I mean, the clinical definition of recurrent here is having 2 or more UPIs in just 6 months.
That's awful.
Yeah, or 3 in a year.
Yeah.
It fundamentally alters a woman's basic daily comfort, her ability to exercise, her relationships.
And it's progressive, right? Meaning without intervention, it just keeps getting worse.
It only worsens. Yeah.
So to crack this case for you, we really need to explore the hidden microscopic ecosystem of the human body.
We have to figure out if that objective number on a pH strip is actually the holy grail for tracking a patient's recovery.
Or if it's just, one small piece of a much larger puzzle.
Right. And to even debate how to track the success, we need to understand the physiological why behind the problem first.
Okay, let's unpack this. Let's start with the baseline. What does a healthy environment actually look like at the cellular level?
Well, it really all comes down to estrogen. Estrogen acts as the architect of the vaginal environment.
So it's building things.
Exactly. In a healthy premenopausal state, it's constantly working to maintain the thickness and elasticity of the vaginal epithelium.
Which is the skin lining the tissue.
Right. It ensures this lining is robust. It creates multiple layers of these mature superficial cells.
Okay, so it builds up the thickness.
But the physical thickness is really only half the story. Estrogen also drives a very specific metabolic process.
Oh, fascinating.
Yeah, it forces those mature cells to produce and store glycogen.
And glycogen is just a type of stored sugar, right?
That's the key. That stored sugar is a primary food source for a specific family of good bacteria.
Galactobacilli.
You got it. The entire vaginal microbiome relies on them. So as these lactobacilli feasts on the glycogen, they produce lactic acid as a natural byproduct.
Making the whole environment acidic.
Highly acidic, usually a pH between 3.8 and 4.5.
And that acidity acts like a chemical shield, doesn't it?
Completely. It creates this invisible barrier that makes the environment incredibly hostile to invasive pathogenic bacteria.
It keeps the infections out.
Ex-
Okay, so if we introduce an aromatase inhibitor to treat breast cancer,
And the estrogen is systematically shut down.
the whole architectural foundation just collapses.
The tissue literally thins out. Without estrogen signaling the body to build those layers, the cellular makeup shifts completely.
So you lose those robust superficial cells.
Right. And you're left with this super thin layer of immature, fragile cells.
And I'm guessing those immature cells don't have the machinery to make glycogen,
Exactly. The sugar supply plummets.
meaning the good bacteria lose their food source entirely.
The lactobacilli literally starve. And as they die off, the lactic acid production just halts completely.
And without the acid, the pH shoots up.
It rapidly crosses the 5.0 mark. It becomes way more alkaline.
And an alkaline environment is exactly what those invasive pathogens are waiting for, right?
Oh, it's an open door for them. This alkaline shift creates a profound imbalance. Pathogens that would normally just get neutralized by the acid are suddenly able to thrive.
And that leads to the chronic inflammation, the tissue damage, the recurrent UTIs.
Everything that makes GSM so devastating.
Yeah.
You know, I was trying to picture this cellular process while reading the sources for you guys, and it felt a lot like a vibrant rainforest ecosystem.
Oh, I like that.
Right.
Right.
Like if estrogen is the daily rainfall, it's constant and nourishing,
And because of that rain, you have this lush, thick canopy of leaves.
which would be your thick epithelial lining.
Yeah.
And the fallen leaves from that canopy create a very specific, highly acidic soil chemistry on the forest floor.
Which supports the healthy plants and keeps invasive weeds out.
Exactly. But then the cancer treatment brings this sudden, severe drought. The rain just stops overnight,
So the canopy dies back, it thins out.
which means the soil chemistry completely changes.
The pH spikes.
Yeah, the healthy plants die off.
Yeah.
And what you're left with is this bare, cracked, fragile ground.
And it's immediately taken over by thorny, invasive weeds.
Exactly. Pathogens and UTIs.
If we connect this to the bigger picture, that analogy highlights the core reality of managing this condition in oncology survivors. Because it's not just a surface-level issue.
No, we aren't just trying to put a little soothing lotion on dry skin. Treating this is about actively rehabilitating a totally collapsed ecosystem.
Which brings us to the diagnostic debate and the core mystery we are trying to solve for you today.
Right.
Since we know definitively that the pH spikes above 5.0 when the ecosystem collapses,
It begs the core question.
is measuring that exact pH the absolute best way to track the disease and the treatment?
Well, researchers and clinicians have wrestled with this extensively.
Because there are objective tools.
Yeah, we have the Vaginal Maturation Index, or VMI. A clinician can take a small swab, look at the cells under a microscope, and mathematically count the ratio of mature to immature cells.
The sources also talk a lot about simple pH testing strips.
Those are incredibly common.
Right, a doctor can just use a dry cotton swab, touch the vaginal sidewall, apply it to a test strip, and watch the color change.
If it goes from a light green baseline to a dark blue or green, it proves the pH has risen into that alkaline danger zone.
It's a fast point-of-care test.
It is. And finding a pH greater than 5.0 strongly supports the diagnosis.
Okay, but then I read the 2020 guidelines from the Menopause Society, and they clarify something wild.
That the lab tests aren't strictly essential.
Yes. Wait, I'm genuinely confused here. If this little strip of paper turns dark blue and gives a doctor mathematical proof that the tissue is failing, why isn't it the primary mandatory tracker?
It raises an important question.
Shouldn't science rely on hard data rather than subjective surveys?
Well, clinical studies have revealed a really frustrating disconnect here. The severity of a patient's physical symptoms does not always correlate perfectly with their pH number.
Really? So the number can look terrible, but the patient feels fine?
Or vice versa.
Yeah.
You could have a patient with a highly elevated pH of 6.0 who reports only mild discomfort.
Wow.
And conversely, you can have a patient whose pH is sitting closer to normal, maybe a 4.8, but they are experiencing excruciating pain, tearing, and daily agony.
So if a doctor is just treating the number on the chart, they might completely ignore the patient who is actually suffering the most.
Exactly. Which is why they lean heavily on alternative tracking metrics.
Like what?
Things like the day-to-day impact of vaginal aging questionnaire, the DIVA, or, more simply, tracking the patient's most bothersome symptom, the MBS.
Right, the MBS. So the clinician will sit down and just ask, what is the single worst part of this for you?
And they track the improvement of that specific subjective complaint over time.
But doesn't that introduce a huge margin of error? I mean, a patient might feel too embarrassed to report their pain accurately.
That is a very real challenge. And it's why returning the pH to that 4.5 to 5.0 range is still an invaluable tool.
Because it proves the treatment is chemically working.
Yes. But the ultimate goal of medicine isn't just to fix a number. It's restoring the patient's quality of life.
You aren't treating a pH strip, you're treating a person.
Exactly. So the consensus is a dual-track system, using the most bothersome symptom alongside vaginal pH to assess the true clinical response.
Okay, so that makes a ton of sense. Now that we understand what we are treating and how we measure success, how do we actually fix it?
Well, for oncology survivors, we have to look at non-hormonal options first. It's the crucial first line of defense.
And reading through the sources, there's this huge focus on something called osmolality in drugstore products.
Yes, this is a massive hidden danger.
I hadn't heard the word osmolality since high school chemistry.
Most people haven't. But first, we have to distinguish between lubricants and moisturizers.
Okay.
Lubricants are used during intimacy just for friction. Moisturizers are used 2 to 3 times a week for long-term tissue hydration.
But both of them have this osmolality issue.
Right. Osmolality is simply the measure of dissolved particles in a fluid.
Okay.
The World Health Organization recommends products have an osmolality below 1,200 millimoles per kilogram.
And ideally, it should match the body's natural physiologic range, which is around 280 to 310, right?
Exactly. But when researchers tested commercial, water-based drugstore lubricants,
The ones that often contain glycerin.
yes, they found they are heavily hyperosmolar. We are talking 2,000 to 6,000 millimoles per kilogram.
Here's where it gets really interesting. Because of the rules of osmosis, fluids want to balance out.
Right.
So if you put a highly concentrated hyperosmolar gel into a dry environment, it doesn't hydrate the tissue.
No, it pulls water out of the surrounding epithelial cells.
It's like drinking seawater when you're dying of thirst.
That is a perfect analogy.
It might feel wet initially, but on a cellular level, it is actively accelerating your dehydration.
And causing severe microtrauma, increasing the risk of bacterial vaginosis. It's deeply damaging.
Wow. So what should patients use instead?
Proper pH-balanced isoosmolar products, things with polycarbophil or hyaluronic acid.
Because they actually match the tissue's natural chemistry.
Right, they adhere to the tissue. Studies even show a single application of polycarbophil can actively maintain a lowered physiologic pH for up to 80 hours.
Wait, 80 hours?
Yes, proving that non-hormonal treatments can directly stabilize our tracking metric.
Okay, but what happens when the ecosystem is so totally damaged that even those perfectly formulated moisturizers aren't enough?
That's the hormonal minefield.
Yeah, because for moderate to severe GSM, the sources say low-dose vaginal estrogen, or DHEA, are highly effective.
Very effective.
But for a breast cancer survivor on aromatase inhibitors, medications specifically designed to starve the body of estrogen.
It sounds absolutely terrifying.
Right. It feels completely counterintuitive.
The clinical consensus, though, like from ICE and the Menopause Society, has carefully unpacked this.
And what did they find about systemic absorption? Like, does it get into the bloodstream?
Well, initially, yes, a tiny bit, because the tissue is so thin. But after regeneration and cornification of the vaginal skin,
Cornification meaning it rebuilds that thick structural wall.
exactly. Once that wall is built, systemic absorption drops incredibly low. It remains well within postmenopausal levels.
So it's basically self-limiting.
Yes. Therefore, guidelines do support its use after a shared decision-making process with an oncologist.
So what does this all mean for our primary metric? If a clinician sees the patient's local pH dropping perfectly back down to 4.5 because of the estrogen,
Does that success actually scare the oncologist?
yeah. Does a perfect local pH imply systemic danger?
What's fascinating here is that the exact opposite is true. A normalized vaginal pH is actually a sign of local success, not systemic danger.
How so?
It means the localized tissue has thickened enough to produce glycogen and support lactobacilli again.
Ah, so the thick wall is back.
Right. The normalization of the pH is exactly what clinicians want to see. It proves the localized barrier is restored.
Which ironically helps prevent the microtrauma that could theoretically allow more absorption.
Exactly.
Wow. Okay, so to wrap up this deep dive for you listening, to answer our core focus, localized tissue pH stability is a powerful objective biomarker that proves an ecosystem is chemically healing.
But it should not be the sole primary tracking metric.
Right. It must be paired with the patient's subjective, most bothersome symptom to truly measure clinical success, especially for oncology survivors.
And remember, the actionable takeaways here. Please check the osmolality and pH of your over-the-counter moisturizers and lubricants.
Avoid the glycerin trap.
Yes. And know that even for cancer survivors, safe, highly effective hormonal and non-hormonal options exist if you advocate for yourself.
Absolutely.
You know, it leaves me with one final thought to ponder.
Well, let's hear it.
If a localized microscopic ecosystem in our bodies is so exquisitely sensitive that simply applying a hyperosmolar, improperly pH-balanced drugstore gel can cause cellular dehydration and dysbiosis.
Yeah.
How many other subtle, delicate chemical balances in our bodies are we unwittingly disrupting every single day with our modern cosmetic and hygiene routines?
Oh, wow, that is a wild thought to leave on. Keep asking questions, keep reading those labels, and we'll catch you on the next deep dive.